I'm Nupur Rajay, the director of the Center of Multiple Myeloma at MGH Cancer Center in Boston and a professor of medicine at Harvard Medical School. I'm here in Chicago at the annual Society of Clinical Oncology meeting 2017, and I'm here to talk about the data we just presented at the morning oral session at ASCO. I presented data on a large randomized trial comparing Denosumab to zoledronic acid for the treatment of myeloma-related bone disease with a specific focus on renal toxicity as well as reduction in skeletal-related events. This was a very large randomized double-blind trial of nearly 1,718 patients, and these patients were accrued globally from nearly 29 different countries with close to 260 study sites. What we did here was randomize patient one-to-one to receive either zoledronic acid, which was the standard of care, or placebo, versus Denosumab, which was the experimental arm, at a dose of 120 milligrams subcutaneously given every 4 weeks. The primary endpoint of the study was time to first on-study skeletal-related event, and the secondary endpoints were to look for a benefit in terms of superiority with respect to SREs as well as subsequent SREs. What we found in the study with Denosumab, which is a known humanized rank ligand inhibitor, which is known to be significant in the cause of osteolytic bone disease, was the fact that the time to first on-study SRE was equivalent whether a patient got Denosumab or zoledronic acid, suggesting that this was a non-inferiority study, which was our primary endpoint. The secondary endpoint of superiority was not met. We went on to further look at overall survival in this newly diagnosed patient population, and we did not see a survival difference between zoledronic acid and Denosumab at the time of last follow-up. But most importantly, what we also saw was a very significant benefit in terms of progression-free survival with Denosumab, which was the experimental arm, compared to zoledronic acid, of almost 11 months if the patient got Denosumab as opposed to zoledronic acid. Other important features which were noted, toxicity-wise, both of these compounds were generally well tolerated, but when we drill down into renal toxicity, which we did because the bisphosphonates typically are renally cleared and one has to modify doses based on renal toxicity. We looked at renal toxicity in this patient population, and what we did see was that the incidence of renal toxicity was significantly higher in patients getting zoledronic acid. We also saw that if the creatinine clearance was less than 60 ml, we saw a doubling of this renal toxicity in this patient population, suggesting that Denosumab probably is a safer and a more effective agent in this setting, which we all know affects a significant number of patients with multiple myeloma. So based on this very large international randomized trial, what we were able to conclude was that from a bone disease impact or from a skeletal-related event impact, both zoledronic acid and Denosumab were equivalent. We saw a very encouraging progression-free survival benefit of close to 11 months for Denosumab, and more importantly, we also saw improvements in terms of renal toxicity side effects in Denosumab as opposed to zoledronic acid.